I wanted to just present something in a minute because I thought Dr. Maria did an unbelievable good job and covered everything that really needed to be covered regarding breech birth. But I wanted to talk a little bit about what was said by Anna Rita and Dr. Maria first. And then I want to present some data that on home breech birth, which of course is not something that I'm advocating for here, but I just want you to see what can be done with properly selected breech candidates in an environment that's nurturing. So, but first I made some notes before. I don't know how old Anna Rita is. Okay, because she mentioned her age was a problem. She mentioned at the very beginning, and I want to make sure that everybody here knows that when you're over 35, you're not suddenly a geriatric pregnancy, okay? That your body doesn't suddenly fail, and when physicians tell you that, it's told you because it's an old-fashioned, oh, sorry, I'll just put it, yeah.
It's fine, you can be,
okay. It's an old-fashioned thing that comes way back from the era when amniocentesis was done before ultrasound, and the risk of miscarriage from an amniocentesis was the same as the risk of Down syndrome at age 35. And that's where 35 came from, and it's been carried on forever since. It makes absolutely no sense. So again, for reassuring purposes, you're not suddenly, your body suddenly doesn't change over at 34 years and 11 months and then suddenly becomes high risk. I don't like when people say that. I also want people to know that in frank breech babies toward term, they often have low amniotic fluid. And I don't know if it's a cause or an effect, but it's something that I've witnessed for my entire career, that they'll have fluid. If you understand AFI, it'll be 5, 6, 7, 8, and people will call that low, but it's actually quite normal for a term frank breech baby. So again, if a physician doesn't understand breech or wants to frighten you, he can tell you that you're over 35 or that your fluid is lowish, but that is not something to be nervous about in those specific circumstances if the rest of the biophysical profile on your breech baby is fine. She also mentioned that she's fearful of external version. A lot of people are, and if women had choices of quality birth teams or centers where breech was an option, then external version wouldn't be the only choice. The problem is it's either external version or cesarean section for most women around the world, all right? And that's not a good thing because external version, if you're given the risks or informed consent for external version, a lot of women are going to choose not to do it, and their only choice is to have a C-section, and it's putting them between what we call a rock and a hard place in America. I don't know if that translates well, but
Entre a espada e a parede.
Oh, what did I say? What did I say? Between the sword and the wall. Okay, got it. The rest of it also, I think it's really important what Dr. Maria said about having a breech team. That is key, and you guys are lucky in Lisbon to have one, and you should frequent it and you should spread the word to get as many people there as possible because that's the only way we're going to have training in the future is for people to have large enough samples to go, and you had 21 or something in a year? That's really good. I mean, in 6 years, in what? Oh, preemies, yeah, yeah. Right. And then your weight limits are very strict, 2,000 to 3,500 grams. Again, we're using ultrasound to estimate fetal weight. Ultrasound is notoriously bad at estimating fetal weight, but you have to have cutoffs at some points, and that's why they use 3,500 grams. In my own practice, it used to be 4,000. Now I actually use 4,300 because I've had breech babies that are 9 pounds, and they deliver just fine. And what I found is I'm not worried about the aftercoming head getting trapped. What people are worried about when they have a big baby is that the head's going to get stuck, but the body is just as big as the head. So if the body comes out, the head can come out, especially if those people who attended my session yesterday know that there's things that you can do to get the head out. So to limit a woman because her baby might be over 9 pounds and not give her the opportunity is really not necessarily a fair thing to do, all right? My feeling and my experience is that breech babies with labor that is not augmented or induced will succeed or not succeed for the same reason that head first babies do. There's really no significant difference, all right? I want to go down. we've talked about mammalian birth before. I want to get, okay. Well, this is a flow chart from the paper that we have in press. I did it with a researcher named Rixa Fries. She's a PhD. She lives in France. Some of you may have read some of her stuff. She's very prominent in breech delivery, and she was a big help on this. But these were all deliveries done by me and my team. And there were 60 breech and 109 cephalic presentations. And normally when you look at a breech paper, like the term breech trial or a promoter study, they compare vaginal breech to cesarean breech. And ultimately, they don't compare it to the thing that's most closely related to, which is head-down babies. And they always assume that breech babies are high risk, but they never put in the background risk of the head-down baby. So we wanted to compare and see what the difference was in the success rate in a practice where we use the midwifery model of care, and we don't augment. This is in the home setting, so there's no epidurals. People are free to move about. They're free to get in water. They're free to eat, get on all fours, get on their side, go for a walk, lie down, take a nap, all the things that you'd want to do when you're in labor. And of those 60 breaches, you can see that 10 were transferred prior to labor. And of the cephalic babies, there were 7 that were transferred prior to labor, and I'll get to the reasons in just a second. And of the 50 breech babies that went into labor, 40 delivered vaginally at home for an 80% success rate. 10 were transferred to the hospital, where 2 went on to deliver vaginally, but that option no longer exists in Los Angeles. That physician has since retired, and there's nobody who will take a home breech transport and continue to allow them to deliver. So now we consider every transport to the hospital as a woman going in to have a cesarean section, but at least they know that they needed it, as opposed to somebody who just got scheduled and had an elective cesarean. So there's a lot more, I think, mental satisfaction even when they feel sad that that happened. With the cephalic pregnancies, you can see that 91 delivered at home and 11 were transferred, and of the 11 transports, 8 still went on to deliver vaginally. With cephalic babies, you have the option of an epidural and Pitocin. With breech babies, we really don't have that. So we had a cesarean section rate of 3 in 102, which is a 2.9% cesarean section rate in the head-down babies. And we had a 16% cesarean section rate in the breech babies, which I would consider 20% in the future, simply because we don't have that option. Both of those numbers are pretty good when you compare it to what goes on in the hospital setting. These are the reasons that care was transferred antenatally, and you can read that carefully yourself. If you can't read English, it's basically 41 weeks suspected macrosomia, cholestasis. 3 of them I was out of town, like doing lectures. 2 were for low amniotic fluid and lower than what I just described earlier. 1 was for being ruptured for 5 days and never went into labor. And I know some people may roll their eyes at that, but actually there is data to support non-intervention in those patients. We often do it when babies are premature. They'll rupture their membranes at 32 weeks. They'll put them in the hospital. They'll keep them there for days. But for some reason, if they're at home, that's wrong. It really isn't. As long as you're not examining them or bothering them, probably safe for their own bacteria, their own environment is in the home. And 2 were for greater than 42 weeks, not in labor. For the cephalic ones, you can see that 1 had developed preeclampsia, 1 was greater than 42 weeks, 1 had a fetal demise, 1 had polyhydramnios, 1 had increasing blood pressure problems, 1 had non-reassuring fetal heart rate tracing, and 1 developed a deep venous thrombosis at 34 weeks, ended up going into preterm labor and delivering. Right, I highlighted the things. I'm going to try to just limit to the highlighted things here. You can see that 82% of the breaches delivered vaginally. Oh, excuse me, 82% were primips, where only 57% were primips in the head-down group. So that's going to obviously skew your statistics a little bit towards cesarean section for breech, because across all types of pregnancy, breech delivery, primips are more likely to end up with a cesarean section. We found 90% of our breaches to be frank, which was a little higher than what Dr. Maria had found. And then we had only one macrosomic baby in the breech category, but we had 16 macrosomic babies in the cephalic category, and that's because with the head-down babies, we have no limit. And with the breech babies, we set a limit of 4,300 grams. So we were being more careful with the, I see a puzzled face. Does that make sense to everybody? Okay. This is the location of birth and the mode of breech birth. Out of hospital, 40 or 80% delivered out of the hospital, and 89.2%, as I said earlier. There were 20 forceps or vacuums in the cephalic group. The reason that that is so high is because part of what I do in Los Angeles is I help midwives who have clients that have been pushing for several hours at home, and their only option would be to transport to a hospital for a vacuum or for a forceps delivery, but I can come to the house and do that, and so that's why that number is skewed very high. These are the reasons that women were transferred in labor, and you can see that for the breech babies, they were all for arrest of dilatation or descent. And for the cephalic babies, 6 of them were, 3 were for maternal exhaustion. We didn't have any maternal exhaustion in the breech group because they knew that if they were exhausted, they'd have to get a C-section. So they stuck it out a little bit longer. Whereas the head-down babies knew that they could go get an epidural. And then we had 2 that were, had abnormal fetal heart rate. We don't do tracings, actually we use intermittent monitoring, but they had abnormal fetal heart rate patterns in labor. Didn't have any abnormal fetal heart rate patterns in the 50 breech births, though. The part that's pink here, you'll see that the episiotomy rate for breech babies was 12.5%, and it was 11% for the cephalic. That is actually a low. Excuse me. That is actually a low rate, but it's higher than the midwifery model would like. But that's again because a lot of those babies I'm being called to deliver them when they've already been pushing for 3 or 4 hours, and they needed help. Perineal outcomes, I'm going to skip that, but you can actually see that the multips had really no trauma, and that maternal position, even though there were only 11 in the upright position, I was trained in the lithotomy position where women are on their back, and that's what I did for 28 years in the hospital. That's what I was most comfortable with doing breeches. But in the last few years, there's been a lot of push to women on all fours, so I've started to do it that way. And you can see it does fit with the recommendation or the finding that women on all fours have less perineal trauma than women who are on their back. And this is the APGAR scores, and this does fit also with findings with breech. We had statistical significance in the low 1-minute APGAR scores, but not in the 5-minute APGAR scores. Time's up. All right. Okay, so I'll quit there, but I just wanted you to be able to see that it can be done at home. All right, these are the results. So rates of vaginal birth for both breech and cephalic groups were high, with 80% of breeches and 97.1% of cephalic mothers giving birth at home. And then morbidity, we have very little morbidity on either side. I'll just skip that because it's really not statistically different. Okay, the relatively small sample size of this group limits our ability to extrapolate these numbers to bigger groups. However, this is the largest study of planned out-of-hospital breech births with a single care provider in the history of recorded time. So we need more data, as everyone always says, but I think we all agree that the people that came yesterday and Dr. Maria, we also think that properly selected breech delivery is a really reasonable option, and the key is that it should be taught as a core skill. It shouldn't be taught as an emergency skill. It should be taught as a core skill. Anybody who's becoming an obstetrician should demand as a resident to learn this skill, because it's one of the things that makes OBGYNs unique and special, is that we can do a breech delivery, we can do a forceps delivery. We can reach up and pull out a second twin by doing a breech extraction. To only do cesarean sections does not make us obstetricians. And I know I ran over, so I'll quit.